So in this video, we'll be learning about the treatment of alcoholism or alcohol dependence. Coming to the introduction about alcohol or ethanol, it is an aliphatic alcohol which causes the syndrome of alcoholism. Now, how do we treat the alcoholism or alcohol dependence? Now, there are two steps for this. First one is the process called detoxification. This is done to treat the withdrawal symptoms. In order to treat the withdrawal symptoms, you first detoxify. Then what do you do after that? Then after that, you undergo a process called rehabilitation. Now, in rehabilitation, what we do is that we ensure that the patient or the person, the individual is undergoing, or the patient achieves a complete withdrawal. That means he or she does not tend to drink alcohol again. And for rehabilitation, we use some drugs. So in this video, mainly we'll be learning about those drugs. So coming under the drugs used for rehabilitation, you can divide the drugs used for rehabilitation to two categories. The first one is drugs that make the ethanol consumption unpleasant. And the second category is the drugs used to decrease the cravings of, the effects that is given by alcohol. So coming under the first category, which is the drugs that make ethanol consumption unpleasant, we have two drugs. One is Disulfiram. Second one is citrated calcium cyanamide. And coming to the second category, that is the drugs used to decrease the cravings, you have three drugs. One is Naltrexone, then is nalmefene and Acamprosate and topiramate. Now, in this video, we will not be learning about all these drugs. Why? Because all these drugs are not approved. All these drugs are not FDA approved. As you can see here, only three drugs are FDA approved, and those are the ones which I have put under the box, which is Disulfiram, Naltrexone and Acamprosate. These three are the only FDA approved drugs for treating the alcohol dependence. Now, coming to the first drug, which is Disulfiram. So in this drug, I'll be explaining the mechanism of action of Disulfiram. So how does Disulfiram work? Now let's assume that I consume alcohol. So this is the alcohol, as you can see. Don't mind the color. So let's just say that I consume alcohol, and this is ethanol. Ethanol. Now you see the soldier over here. It's actually an enzyme that I have drawn over there. Now this enzyme is called alcohol dehydrogenase. Dehydrogenase. Now this enzyme, that is alcohol dehydrogenase, reacts with ethanol. And what does it give you? It gives you a compound known as acetaldehyde. Acetaldehyde. So now the cycle does not stop there. After the ethanol gets converted to acetaldehyde with the help of alcohol dehydrogenase, it undergoes a further more metabolism. Now this acetaldehyde again gets metabolized by the enzyme aldehyde dehydrogenase. As you can see, the first enzyme that acts is alcohol dehydrogenase, and the second enzyme that acts is aldehyde dehydrogenase. Now, what happens after the aldehyde dehydrogenase acts with acetaldehyde? Now, the acetaldehyde gets converted to, you see this green substance over here? Yeah, that is nothing but acetate. Gets converted to acetate in our body, and this acetate again breaks down to CO2 and H2O. This is how the normal metabolism of ethanol occurs. Now, how does Disulfiram act? Now, I'll come to that part. Now, Disulfiram simply inhibits this dude over here, which is known as aldehyde dehydrogenase. The color. So you see this dude. So what disulfiram simply does is that it inhibits the aldehyde dehydrogenase. So when it inhibits the aldehyde dehydrogenase, there is no enzyme left to metabolize the acetaldehyde. So what happens? So what happens is that the acetaldehyde gets accumulated in the body. It gets so much accumulated that it leads to, I'll just write here, it leads to accumulation of acetaldehyde. Now you must be wondering, how does that cause any harm to us? No, it's not that simple. Acetaldehyde is basically toxic for our body. Now accumulation of this acetaldehyde will lead to a lot of harmful symptoms in our body, which can last up to 30 minutes to 1 hour. And these symptoms, or the distressing symptoms, are mainly called as aldehyde syndrome. Yeah, you can call them also as aldehyde syndrome. And what are these effects that they cause? They cause you flushing, burning sensation, I'll just write this over here. This is throbbing headache, this is, as you can see, it's vomiting. And this one might be hard to understand. It is actually tightness in the chest. So these are the 5 distressing symptoms, or symptoms that is caused by the accumulation of aldehyde in the body. And like I said, it lasts up to 30 minutes to hours. It can last in the body. So why is it given? It's given because in order to make the person, make the person less addicted to the alcohol or ethanol. And also coming to the pharmacokinetics. Now, what are the pharmacokinetics of disulfiram? Now, the pharmacokinetics of disulfiram is that it is rapidly absorbed in our GI system. So I'll just write this over here. Rapid absorption. Then the second one is that it is lipid soluble. I've drawn a fat cell over here, which means it is lipid soluble. Now what does that indicate? How does that help us, with this whole thing? Now it's lipid. What it means is that since it's lipid soluble, it can be easily distributed in our body. That is, easily distributed in the body fat. In body fat. And coming to the part of metabolites, its metabolites are excreted in urine. So these are just the broad pharmacokinetics of disulfiram. I'm just going through the layer. Now coming to the drug interaction, I'll not be discussing about the drug interaction for the other 2 drugs. I'm explaining for disulfiram because it is comparatively a much important drug when you compare to the other 2 drugs. Now coming to the drug interactions, the disulfiram, when disulfiram reacts with metronidazole or isoniazid, it causes CNS toxicity. Now what happens when disulfiram reacts with diazepam? Now when it reacts with diazepam, it leads to an increased CNS depressant effect. So it causes what? It causes CNS depression. Now, what happens when disulfiram reacts with dopamine agonists? Now, what happens is that it leads to an increase in dopamine level. Now, it is good or bad, I'm not sure, but it can cause things like insomnia and psychosis. Insomnia and psychosis can be caused due to the excess levels of dopamine. Now, coming to the contraindications, disulfiram is mainly contraindicated in patients with MI or myocardial infarction, in patients with diabetes mellitus, DM, and I've drawn a clock over here, which simply means that it's contraindicated in any patients that have received alcohol less than 12 hours. So, alcohol consumption, I think, alcohol consumption less than 12 hours. Now, why have I written less than 12 hours? It means that our body requires a minimum duration of 12 hours to excrete the alcohol or the alcohol which we have taken. So any patient, unknowingly, if they have taken alcohol less than 12 hours and they take disulfiram without knowing it, it can cause this severe reaction which I've mentioned above. What was it? Flushing, vomiting, throbbing sensation, tightness in the chest, etc. Now, coming to the second drug, acamprosate. Now, these, like I've told before, acamprosate and naltrexone comes under the category of drugs which is used to decrease the craving effect. Disulfiram does not decrease the craving effect. Whereas acamprosate and naltrexone, these agents act by decreasing the craving effect. So how does acamprosate actually work? Acamprosate has two mechanisms. One is that it inhibits the glutamate. Now, glutamate is what? Glutamate is an excitatory neurotransmitter. Now, how does it help? Now, what happens is that when you consume alcohol or ethanol, you have the withdrawal effect mainly due to the effect of glutamate. Glutamate is the neurotransmitter that gives you the craving effect. So what does this acamprosate does? It inhibits glutamate, and at the same time it enhances the GABA. Now, what is GABA? GABA is an inhibitory neurotransmitter. So what it does, it decreases the glutamate, whereas it increases the GABA. So what does it do? It balances the neurotransmitter. 2 points. It tends to balance out the neurotransmitter levels. If the glutamate was increased, it would have led the patient or the individual to have an excited behavior, leading to its withdrawal symptoms. So this is how the acamprosate works. It has two mechanisms. One is that it inhibits the excitatory neurotransmitters, and the second one is it enhances the inhibitory neurotransmitters. Coming to the pharmacokinetics, coming to acamprosate's pharmacokinetics, it is simply it has a poor absorption. Unlike to disulfiram, it has poor absorption. Coming to the food, presence of food decreases the absorption. So in general, I feel like the acamprosate has comparatively less absorption. And the third one is that it it is widely distributed in the kidney. So since from pharmacokinetics you can understand that since it's widely distributed in the kidney, you can understand that it's contraindicated in patients with renal impairments. So these are the pharmacokinetics for acamprosate. Now coming to the third drug, the final drug, which is naltrexone. Now naltrexone works in a completely different manner. So I'll tell you. So this is the brain of the person. Imagine, let's just say this is my brain, okay? So you see this nerve over here. So this is the presynaptic neuron. Presynaptic neuron. What is this? This is a synaptic cleft. Synaptic cleft. And this is postsynaptic neuron. Now I've marked some dots with pink color. So what is pink color? It is opioid ligands, and the blue receptor, it is opioid receptors. Now, so you can understand that the cells in our brain have opioid receptors in it, right? So opioid receptors need what? They need the opioid or the opioid ligands. So how does naltrexone actually work? So let's just say a scenario where there is no naltrexone, okay? This is a normal scenario. Let's just say I'm drinking alcohol. I'm drinking alcohol from a cup. It goes into my mouth. So what happens in a normal condition? So in a normal condition, when I drink alcohol, it leads to the activation of the opioid receptors by the opioid ligands. So this opioid's activation is the reason why you get an inducing effect of alcohol. The people always seem to be drowsy. They have this sedative effect. So that is caused by the opioids. So it is caused as a result of the activation of the opioid receptors. So what happens when you take the naltrexone? So when I take naltrexone, suppose I take naltrexone before consuming alcohol. So now what happens is that this naltrexone, instead of letting the opioid ligands to bind here, the naltrexone comes and it binds over here. So what happens over here? So when naltrexone binds over here, the opioids cannot bind to its receptors. So that leads to a disruption in the activation of the opioid receptor, and therefore it causes or it prevents the inducing effect caused by the alcohol. That is how naltrexone helps me to decrease the craving effect. Now coming to the last portion of our video, which is the pharmacokinetics of naltrexone. I'll quickly end this. Naltrexone is absorbed in the GI tract, absorbed from the GI tract. It is heavily metabolized in the liver, heavily. So which means that if any patient has any liver impairment, he or she will be having difficulty with taking naltrexone. And the third one is that naltrexone's half-life is around 4 hours. And please note, it is comparatively a long-acting drug. So that's it for today.